And we'll talk about a little bit about loading implants, okay? And there's sort of different ways of doing it. And we do a lot of immediate loading, and we should go for an hour or so. I'm going to talk about relating to that to like single cases, partial and full arch. And really, the aim tonight is to sort of discuss loading, show you a little bit how to carry this out, but also give you a bit of an insight of what sort of, it's to whet your appetite as much as giving the very nitty gritty of it. So to show a little bit of what's possible, a little bit of how to do it, not necessarily sort of every last bit of detail, because that's really more of an expanded course really. So the question is, it's always good to know your audience, who here places implants? Just raise your hand. Raise them again. So only a few of you, is that right? You guys don't put implants in. So who restores implants? Most or a few. So who does both? A few, 3, 4, okay. So if you've got LifeCare patients that need it, they send it to you guys or to Alex, etc. Does that sound right? So next question is, who's carry out immediate loading? Anybody? 1, 2, 3. Right. Okay, so that's what I'm sort of talk about a little bit tonight. And what I'd like to just briefly mention is, as I get older, I mean, less than that people know me, so I'm sort of talk a little bit about what we do in my own practice, sort of what I call the scope of practice. And about 50% of my practice consists of implants, implant treatment, okay? And it could be a single tooth like that with a high smile line and work through the radiology department, not far from here. There's just another single tooth and go from that to that. And I can tell you now, I mention it, and I sort of tend to sometimes repeat things because I want to emphasise it. And with implant treatment, the two sort of scenarios I get the most enjoyment from, basically a single tooth like that where the patient's lost a central incisor, sometimes endo, sometimes trauma, you can restore it and leave the other teeth alone. The other situation that really is very satisfying is the full lower hybrid. People that have trouble wearing full lower dentures, and it's really, they come back as a really, really good practice builder, and they kiss your feet. So the two ends of the spectrum, a single upper central or full lower arch hybrid, they're both really good practice builders. We do a lot of partial cases as well. There's anteriors, posteriors, there's 2 lower anteriors there. You see some of these down the track. There's a freehand saddle there. There's all sorts of combinations. And, I'll certainly mention in the second half of the talk about immediate loading and full arches. And, if you haven't heard the term all on 4, you're not living on the planet and you're living under a rock sort of thing. We'll discuss that a little bit down the track. There's an upper arch to all on 4 and a lower arch. But an all on 4, and one of the messages I'd say is an all on 4 is not a panacea. You sort of think that there's sort of practices that everything's an all on 4. If you've got a few teeth left over, you take them out and do an all on 4. If you need a full arch implants, you do an all on 4. It solves everything. And that's far, far from the truth, okay? In some cases we use 6 implants, we're going to go further back in the arch. Sometimes there's not enough bone, we use zygomatic implants, or in this case quad zygomatic implants. Sometimes wiggle it out, combining with anterior implants. So all those are possible. And we'll see some of that down the track. The other half of the practice is sort of crown and bridge restorative dentistry, where it's got veneers, like a single veneer. We do a lot of all ceramic type restorations now, a lot of it's zirconia. A little bit of it's monolithic, not a lot. So we do a lot of that, and there's like a single veneer there, and that's an old crown someone's put in. If you have a look, and we're not here to talk about this too much, but if you have a look at sort of gold proportion ratios and things, the size of that lateral is just about as wide as the central, which really sort of sticks out. So that's a problem. There's a course on that. Here we do stuff like this where it's half a dozen veneers for, enamel problems. And we can do full arches all in ceramic like that. And you can do sort of A1s and A3s, whatever you want. So that's about half the work. And I'll tell you one thing, I'm going to run some courses down the track on treatment planning. I've got a treatment planning session, I think, with you guys in a couple of months' time. You want to have your treatment looking good. What I want to emphasise is the only way your treatment's going to look good is to have good perio. Okay? we go to great lengths to get the perio very healthy, and there's certain things we do in relation to that. And that's just another case, same thing, good perio, that's the biggest thing. And the other thing I'd like to emphasise before we get on to the main thing tonight, a lot of people think, oh, you know, you get all these high end flies. We get 1% of the patients are high end flies, the other 9% are just normal everyday people, same as you people. We get patients like that as well as the other end of the spectrum. And this guy's rehabilitated via implants, as was this guy, I think that's his brother, and this guy, and this guy, and this guy. And I use the term guy in generic terms because they could be just as easily female. So all those patients are my patients, they've all had treatment. They've all walked in the door looking like that. So, the other thing I sort of, sometimes they wanted me to send a photo of myself, so I threw that in for Alex, but he's not here. We run courses on a sort of level 1, 2 and 3 or intermediate, advanced and basic implant courses. And I started that nearly 20 years ago. I established this APEC thing, Australian Prosthodontic Education Centre, it's just a name. And we run a study club, and I've got a mentor scheme. I'm happy to help people, which we do. So, you know, that's sort of the scope of where I'm coming from. Someone here earlier, just a minute ago, asked about the study club. Yes, we still run it. We have 6 sessions a year. It's limited to 10 to 12 people, because that's sort of a good number to discuss things. Run it at my practice just up the road. And the format of the study club, which I've changed now since its original, was it goes for 3 hours. It's always a Tuesday from 6 till 9. And what happens is between 6 and 7 we have a guest lecturer most times, and then between 7 and 9 we just talk shop and talk cases. And this is always advertised in the journal, except now they've changed the format of advertising. Anyone that's interested, the next one's coming up in July somewhere. Get the date, it's there, 24th of July. And Professor Paul Abbott's going to talk about, quote unquote, the root fill tooth now has a periapical radiolucency, what next? And that'll go for an hour. Then you get, 2 hours of talking shop, as it were. There's 3 hours of CPD points. You get 3 pizza, cost you nothing, you get a certificate. So it's always quite, well subscribed. We've had all sorts of people on there. So anyone interested, contact and practice. The other thing I run is those implant courses. And there's a level 1 course coming in August at some stage, and there's still some room on there, and that's the ad for that. And there's a level 3 or level 2 for advanced course a week later, so I sort of get them out of the way. And that's designed for people who've done implants, and again, there's some places on that. And so that's where I'm coming from. So let's talk a bit more about loading. There's a sort of a continuum is the best word. You've got immediate or implant placement, function and loading. Okay, and there's quite a difference. You need to understand the concept about those 3 ideas. Okay, so there's implant placement, implant function and implant loading. By the way, if you've got any questions, please ask as we go. It's sort of we can handle it as we go, so don't be shy. So what I talk about in terms of these ideas is what is it, does it actually work, why do we do it, when we do it, and also how we do it, which is why some of you guys want to know. And I'm going to sort of relate that in single, partial and full arch cases. And again, because of the size of the topic, we're going to sort of skim through a little bit of it. But that's the concept of the overall topic. So what is it? Well, if you look at the loading protocols, or the time frame, if you look at the sort of the recommended, if you start the implant place at 0 hours, in the first 2 days, if you put a restoration on there, it could be a single tooth, provisional, could be a partial, could be a full arch. That's what they call immediate loading. Now that's really sort of okay in a diagram, but I sort of tell it how it is. And the bottom line is, if I'm doing a full arch, that immediate loading is usually about a week. They talk about 2 days. Well, that's not what happens. That's just what happens on the diagram. From implant placement to provisionalisation to a full arch, most times, in my case, it's a week. It's just so be it. Then they talk about early loading in the first 3 months, because the traditional loading is how it all started. We used to do 1 step at a time. We take the teeth out, and I'll show you in a minute. Take the teeth out, let that heal for 3 months, place the implant, let those heal for 3 to 6 months, 3 months the lower jaw, 6 months the upper jaw. Then you make the provisional, let that go 5-6 months, and then you make the final. So it's that's the traditional or two-stage or delayed protocol. And we do that occasionally, but less and less. So there's a progression from immediate placement, one-stage surgery, immediate function, immediate loading. Okay, so and hopefully you also have an idea what the difference is between those things, which we'll talk about now. Immediate placement, people often, just to clarify, you can't have immediate placement in a healed site. If the tube's gone 3, 6, 12 months ago, 10 years ago, it can't be immediate. Immediate is like when you do an immediate denture. You take the tooth out, you place the implant there on the spot. Okay? So, but it's one teeth or all the teeth, immediate placement means at the time of extraction. The other thing you can do is put the implant in, and instead of burying the implant, you do a one-stage surgery, so put a healing abutment. The alternative to that is to bury the implant with a cover screw and uncover that implant X number of months later. If you do all that in one go, it's one-stage surgery, so it's placed at the same time. Now that abutment could be one of three things. It could be a healing abutment, it could be a temporary abutment, or it could even be a final abutment. But essentially it's an abutment that transcends the mucosa. So it's the transmucosal element. And you put a healing abutment on to allow things to heal. You sometimes put a temporary abutment because you're making a provisional. You sometimes put a final abutment, for instance, a multi-unit type abutment where you're doing a full arch. But it's an abutment that goes through the mucosa. It's got a whole number of advantages. It's only one surgical flap. Every time you raise the flap, you likely or may cause more tissue shrinkage. So you go in there once and that's at the end of the surgery. That's the advantage of that. It reduces speed not because the surgeon charges you less, but because you're going to be off work once, you're going to go to hospital if you're doing the hospital once, you're going to have time off work once, and so you're not saving on the dental fees as much as your outside fees. It reduces the treatment time because you can do a couple of stages together, and all of that leads to far better patient management. You can tell a patient you're going to go into surgery once and that's the end of surgery, then you've got the prize. So it's a huge advantage to do that. And I would say, I don't do surgery. I work with 2 or 3 surgeons. I've never done any surgery except teaching the students how to do it. And so essentially, the surgeon can do those 2 stages of surgery and it's all done. Okay? So then all you've got to do is the prize. Immediate function or immediate loading is a difference in concept. With immediate function, it relates to more in the sort of situation of single teeth. And with the single tooth, you can have a provisional in there within a day or 2 or 3, and the patient can, quote unquote, function with it. What they mean is they can smile with it, they can talk, they can sort of chew light foods, but it's out of occlusal contact. If it's in occlusal contact, then it's what we call loaded. So essentially, for all immediate type situations, we try and put in function but not loaded. If you really think about that, when you've got a single tooth, you've got immediate, the provisional is put in there, you can keep that out of occlusion, you make a little, maybe half a millimetre shorter at the incisal, a little bit thinner at the back so the lower teeth aren't catching it. If you've got a full arch, you can't have immediate function because as the patient closes up, it's going to contact somewhere. So you're actually going to immediate loading whether you like it or not. So there's a difference. So there's that continuum I'm talking about. And this is what I just said. Immediate function is out of occlusal contact. Immediate loading, it's in occlusal contact. Okay? Now, this is what I said before about this timeline. This is why we do it. If you look at the timeline, and if the implant is placed there, there's 2 types of integration, the mechanical and biological. And with the mechanical, it's literally a mechanical interlock of the implant against the bone. The implant's got threads, and the bone goes into that, and it's effectively the same integration or contact, if you like, as if you put a bit of a screw into a bit of wood. That's as strong as it's ever going to be. What happens is with the biological integration, you get, you get a histologic change where that's where we get osseointegration. So with osseointegration, the bone and the implant integrates. And that's the biological process. Now what happens is the biological process starts on day one there, and slowly increases till you get to sort of up around here until a couple of months it starts to take off. The mechanical process goes down, and you get to hit somewhere around here and it drops down. So as mechanical integration drops, the biological integration goes up. If you look at the timeline, the critical time's around here somewhere, and that's why we say that you want to place the provisional restoration, or the final if you don't do a final, because you're an idiot, but basically, I'll talk about that in a minute, I've got some strong feelings about that. You load the implant the first 7 to 8 days because of this, and if you don't do that, you don't load it for about 8 to 10 weeks. That's a pretty standard kind of protocol, and that's the reason you do it. This red line means that it just wasn't done right. You get problems with sort of design of surgery, so that sort of means it will just forget that. Okay? So that's the reason we sort of load the provisional within the first week or so, 2-3 days, a couple of days for a single, a week for a full arch, or otherwise you wait. If you do immediate placement and function and loading, there's a whole bunch of advantages. One of the biggest ones is you don't even have to wear a partial or a full denture again. One of the things that we do is once you've had any surgery, which could be an extraction, could be an implant placed, could be a graft, particularly a graft of soft or hard tissues, we basically don't ever want that patient to wear a removable prosthesis ever again. So if they want to wear a partial, get rid of it. I know you can sort of adjust it, undermine it and hollow it out. It's still no good. It still rubs on the tissues. The same with a denture. So, if you do immediate provisionals, you don't have to wear them removable after surgery. You can wear one before, up to the point of surgery, but not before it, not after it. It's shorten your treatment times. That's pretty obvious. And they say it reduces fees because it's all done together. That's not true. It increases your fees. Because, yes, your fees for surgery are the same. You've got increased fees for the provisionals with prosthetics that we make. So it increases your fees. It doesn't. The huge thing is that you get much better patient acceptance. Same as surgery. You sort of go, you go to surgery once and it's all done. Okay? And that's a big plus. So you get far better patient acceptance. The other thing with patient acceptance, and I'll mention it when we talk about provisionals, is one of the things that we, meaning I, promise patients, if you've got upper anteriors, you don't ever go toothless. Okay? What I call a plan A and a plan B. Plan A means you've got immediate loading. When I say you don't go toothless, you might go toothless for a day. I call that not going toothless. But you've got plan A where you get a provisionally sort of screwed into the implant, and plan B you get some sort of what we call a suspension bridge, but not a partial. So you don't even go toothless, which gives you far better patient acceptance. They find it hard to follow sometimes, but we show them models and try and explain it. And yes, because it's done as one go, you get far better, you get less scarring, better soft tissues and less bone loss. And the whole point of some of the provisional concepts is that they keep the soft tissue and bone there similar to a tooth would. And the other big thing, really big thing that's driving this are the market forces. Companies are really pushing this sort of immediate stuff. And in the right circumstances, you've got to be very selective when you do it. That's one of the big messages. You can't do it all the time, but you've got to be selective. When you can do it, we do it wherever possible. And patients are wanting things faster, better, quicker of everything. You know about that. So market forces were a big leader in pushing this stuff. So if you look at the traditional approach, there happens to be a full arch case that applies the same to a single tooth. I'll show one of those next. You take the teeth out, you wait 3 months. This is what we used to do routinely 20 years ago. You then have stage 1 surgery. With stage 1 surgery, you bury the implant, you suture up over it. Okay? And then you wait for those implants to integrate, and that takes 3 to 6 months, depending on which jaw. Then you do what's called the uncovering, which is stage 2. Then you wait 1 or 2 months for that to heal. Then you make the temporary provisional prosthesis, and then you wait 6 months and make a final prosthesis. And from 1 to 5 takes about 18 months. Well, we do that very rarely. So this is here where we've taken the teeth out. Like I say we, as I said, I don't do the surgery. waited 3 months to heal, then put implants in. They've got cover screws, which means they're going to be buried. Suture over again with a membrane suture, and they go away again for 3 months. So 3 months after that, they come back. We put healing abutments on, not any other type of abutment. We let that heal for a month or two. Then we put these other abutments on. These happen to be mother units. And in another 3 months, they're wearing provisional. Another 3 months, they've got a final. And that's how we used to do it. And we still do it like that. 1% of the time, 5% of the time, you know. It's still an option depending on the selection criteria. So the big thing also is that when I'm talking about full arches, we're going to skip a little bit between full arch and singles and partials. But whether you do it all in one go or you do it in step by step, the actual procedure is the same. It's the same steps, but you're going to bunch them up. And that's important to try and remember. So in terms of doing the traditional approach, which I just showed you, in a lower jaw, we probably do it 1 in 100, 2 in 100. You don't, you know, we still do it, but it's 1%. On the other hand, the upper jaw, the bone is not as strong, and we tend to do it maybe 15, 20%. And that's not set in stone, but you get the idea that, you know, we do it a lot, considerably less. But 20 years ago, that would be 0% and 0%. And 10 years ago, that would be 5%, and that would be, you know, 30%. You know, so it's really going better in terms of because of the type of implants and everything's just improved. And the same thing with single tooth. There's a traditional single tooth. This tooth's had, you know, it's had its day. It's had 3 rounds of endo. It's cracked and it's coming out. And so we took this tooth out, waited 3 months, had a partial or a suspension bridge trying to hold that shape in the papillae, and then went and did the next round. I can promise you today, if that was being done today, you'd place an implant at the same time, provided you met the other criteria, primary stability, good oral hygiene, things that you're going to talk about. So this sort of infection would not stop the surgeon putting an implant in. The other parameters might though, but certainly you think about doing it. So this is the same patient, we'll go back one. So they're going to lose that one tooth. And again, I've talked about, you know, having things that satisfy the most, being a single tooth. Is that washing? Yeah. Is that you washing?
Yes, hello, Rick.
Hello, washing. What a surprise.
Yeah, nice to see you.
One of my golf buddies. So, yeah, I mean, this is the same tooth. This is the sort of thing I'm talking about, where you get a lot of satisfaction restoring a case like that, not touching other teeth. And the guy's got a good mouth, good oral hygiene, thin, highly discoloured biotype, which is all the red flags go up. So anyone doing surgery or implants of any sort, if you see this biotype, the best thing I can suggest is refer them to anyone but me. So, and, you know, all the red flags go up. One saving grace was that if you have a look carefully, this pregingival margin is slightly lower. Because I know if I take this tooth out, and when your surgeon takes this tooth out, that's likely to go up a bit or so, which might make it even, not by planning but by good luck. So you see the tooth being taken out, some sort of partial has been put in because it's the old way. And in this case we've got this sort of suspension bridge. Now, do you all know what a suspension bridge is? Yeah? It's really just a true-tane orthodontic type suck down with a tooth inside and hollowed out. So that's a denture tooth. So that's what folks invented this phrase, and I think I invented the concept. We'll get no credit for it. So that's a healing abutment. It's a special one because it's narrow, and they can wear this without touching the tissue. So that's a suspension bridge. Then we put an abutment on, and just an old abutment, anyone recognise it. And then again we wait, and so there's another suspension bridge, and they wear that. Then they get the final crown. If you have a look carefully, this line here is where the temporary suspension bridge or partial is digging into the gingiva, and that will heal. Hopefully it'll heal down here, not up there. And that's just him. He lost that tooth surfing. Funny that. So again, I'm talking about this progression from replacement to one-stage surgery, which I'll explain, immediate function versus immediate loading. Okay? Well, the question is, why can we do it when we couldn't do it before? Well, the why we can do it is because of much better primary stability, both from the macro and micro design of the implant. they're all the implants today are pretty well rough surfaced implants, which means they integrate better, faster, stronger, quicker. And as well as that, they've got all sorts of advantages in the micro design. Now these companies spend millions on working out the exact angle of the pitch and the distance between those threads and how far does the flute go out. So they spend millions on that part of it, as well as the sort of actual chemistry of the surface, and that's made a huge difference. You have to control the loads. I've said if you've got a single tooth, you try and keep it out of occlusion. If you've got a full arch, that's offset by the fact that it's splintered to the other teeth. If you need to get a drink of water, please, someone. Sorry, thanks. I'm running out of voice a little. And the other thing, like I said, you get better, faster osseointegration, and you much, much better improved stability, both primary and secondary. So all these factors allowed us to start loading things like we couldn't do 20 years ago. So I'll address about does it work and when can we do it in a minute. You've got to have good selection criteria. You can't just do it with everyone. People say, well, we do it all the time. Well, we don't do it all the time. We do it a fair bit of the time. Thank you. So I actually worked today. And so you've got to have good high primary stability. Okay, so when that implant goes in, you measure what they call the insertion torque. And you want the insertion torque, generally speaking, to be about 35 newton centimetres or above. Okay, if not, we'll show you what happens. You've got to have good bone both in quality and quantity, and you assess that not just by the CAT scan, but also clinically when you do it. And all the implants now sort of have a rough surface. It's interesting because, when most of my work's carried out with LifeCare implants. I don't have any sort of strict correlation with them. I grew up with them, so I still use them mostly. And they were one of the sort of last ones to introduce a rough surface. They used to poo-poo, I'm sort of talking out of shop here, but they used to poo-poo some of the other companies that had a rough surface. And eventually they got one. And if you're in the secret squirrel club, like I am, you weren't allowed to talk about a rough surface because that was bad. All the other companies did that. And unlike you had a textured surface, it was never rough. It was just only ever textured. So it's like you're not pregnant, you're just having a baby. So the other big thing is we want to try and preserve the labial plate, and if there isn't there, you might have to graft. And when I talk to patients about grafting, they come to us first, then they see the surgeon. We send them on. So when I talk to them about grafting, I say, look, there's 3 options with grafting. Number 1, you don't need a graft, which obviously is the best option. Number 2, they can do the graft at the same time as the implant, which would save time, still cost the same, you pay for the graft, you pay for the implant, as opposed to the third option where you do a pre-operative graft. Then you wait 3 to 5 months and then you do the implant. So it really drags the treatment out. So you're going to have no graft at the same time, or a pre-operative. Okay. And look, we talk about having the extraction 5mm past the socket with the concept of giving a good primary stability. That's not really quite right. It doesn't matter whether it goes 5mm past the socket, or it just engages the side wall, or it goes 1mm past, or 20mm past. What you want is high primary stability. And going 5mm past may give it to you, it may not. Going 1mm past might or might not. The concept was, or used to be, that if you go past the socket, and you can't only do that by 5mm, in most cases, the idea is that you get good primary stability, which is really the critical factor, not the 5mm. You've got to control the loads, which means you've got to have a favourable occlusion and no pronounced parafunction. Now, when it first started, Brandon Mark would say you can't have any parafunction. Well, that would mean that almost nobody could have an implant, because everyone does a little bit of grinding. So what they talk about now is you can't have a pronounced parafunction. If you do have a mild parafunction, you can make an occlusal splint, keep the provisional out of contact, etc. Sorry. So no pronounced parafunction. And you've got to have really good patient compliance in terms of oral hygiene, because the surgery is new, and good oral hygiene. You can assess that before. Even like a single implant, single tooth, if they don't look after the soft tissues around it, they're going to recede. And then you've lost the whole point of why you're doing it as immediate. You've got to start with reasonably healthy soft tissues and no major apical inflammation. I'll talk a bit more about that. If you have that single central we did, that little bit of area at the apex would not worry the surgeon, so long as all the other criteria are met. The really big warning signs are, we're treating a lot more older patients that are medically compromised. And, we've got a whole lecture of 2 hours on medical, and I'm going to just mention 2 things, and that is that, in my experience, in terms of medical compromise, the worst ones are diabetics. And I'm talking about type 2 controlled diabetics, the implants still integrate, they have a much harder journey. And the other thing is patients with mucosal diseases like lupus, pemphigoid, lichen planus. I've treated quite a few of those over the years, and they've all worked, but they've all had issues. The biggest issue is soft tissue. They have a harder, longer journey, same as the smokers. Tissues heal slower. You really don't want any kind of removal in there after surgery. But the actual bone side of things works quite well. Smokers. Look, as far as smokers go, we've treated smokers. Guys that say they've never treated smokers are lying. We've treated smokers. We try and get them to stop a month before, a month after. Where the surgeon's very insistent though is he won't do a graft on smokers. So you can do an implant, no, you can't. It's just like, I'm just being honest, because I usually am. And it's like, we've treated smokers and tell them to stop, and they say, yeah, I've stopped. And we go, yeah, you can smell it that I've stopped, etc. And short implants, we do short implants, but short implants are not conducive to being immediately loaded so much. So you can still use them, but we're a bit wary of loading them straight away. And obviously you want good bone. So one of the biggest things is so-called primary stability, and that's measured a couple of different ways. I'm not going to talk about RFA and ISQ. That's a special machine that there's only about 3 in Perth. It's more for scientific research. Glenn's got one, I know. But what we tend to do is the insertion torque. And so when you insert it, you've got to crank the machine up to a certain torque. The denser, stronger the bone, the more torque you need to get the implant in. And so if you've got 35 or more Newton centimetres, we generally can load or put the implant in immediate function. Okay? A lot of people use the term load meaning function, but so they're sort of interchangeable, people not, the concept isn't. If the insertion torque's around 20, 25, 30, then the surgeon generally do one-stage surgery. So what that means is you don't bury the implant, you do that second stage with a healing abutment or some sort of abutment, and so you're still finished with the surgery. If there's sort of 10, 15, 20 Newton centimetres, then he'll bury the implant. And the big thing there also is that decision is made, certainly in my case, the way I work is it's made by the surgeon. I don't tell the surgeon what to do. I tell him to put an implant in, for say central or full lower arch or somewhere in between, and he'll say, look, I had to bury this implant, Rick, because it's just going to soft bone at 10, 15 Newton centimetres. You cannot load this. You load this, it's going to fail. Or he'll tell me, look, it's gone into 45 Newton centimetres, do whatever you want. And that decision is made mostly during surgery by the surgeon. And then that makes you decide whether you can do a plan A, do a temporary, or plan B. I'll show you both those in a minute. So what that means is, like I said, the final decision is made at surgery. And so you have to warn the patient, we're going to try and load this implant, or do the extraction and put the implant in at the same time, but we may not be able to. And because of that, you go to a backup plan, a plan B. If you can't load it, or if you can't put in, you do a single tooth, you're not going to go tooth, but if you've got a full arch, what are you going to do? We'll show you. Don't, say, under promise, over deliver. Don't promise them something that you can't guarantee is going to happen. The other big thing, of course, is contraindications. I just talked about smokers, medically compromised, oral hygiene. It's all the opposite of what we just said. Okay, very simple. Short implants, again, are very worrisome. Grafted cases, extremely worrisome. Compromised occlusion. What I mean by that is maybe they don't have any back teeth. Maybe they've got a very deep bite, class 2, div 2. Maybe they carry out a lot of parafunction. So it's not a formula that's set in stone. You sort of look at all these parameters and you make a subjective decision, is what I'm saying. The surgeon makes a decision during surgery. We make a decision beforehand based on all these parameters, all the criteria and all the contraindications. And again, I talk about significant parafunction as opposed to any parafunction. And what's significant, you have to make up for yourself and just make up your own mind. So the bottom line is that immediate placement is very desirable, providing you've got good patient management, it gives you a good biologic response. I've talked about single versus splintered restoration. Like I said, if you've got a single restoration, try and keep it out of occlusal contact. If you've got multiple restorations, like a full arch, the trade-off is that they're splintered, so they're going to be in occlusal contact. They're going to hit somewhere when they're finished. And we've got very stringent selection criteria, okay, which are the ones I just talked about. So the other thing is that diagram you just saw. You place the implant immediately, or load immediately, or you wait 8 to 12 weeks because of that integration curve. Okay? And again, if you can't load it, you've got to have a backup plan. So basically, that's what we're talking about at the moment. You've got that continuum where you start with immediate placement, and you go all the way down to immediate loading. Okay? So like I said, there's huge advantage doing that. And does it work? If you keep to those criteria, then it works exactly the same as if you had a delayed approach. If you don't stick to those selection criteria, yes, you're going to have problems, okay? And like I said, it's not a panacea. So the question is, how do we carry that out? Well, let's go back a step if you can't load it. This is our backup plan, okay? For a single tooth, we make this so-called suspension bridge. It's really a denture tooth stuck into a true tone, suck down kind of an orthodontic retainer. We keep it about 1 mil or so off the tissues. And that's what I was saying about the anterior tooth. We promise the patient to never go toothless. And secondly, if they've had any surgery, they can't wear the partial. A lot of people say we can adjust the partial. Well, good luck with that, because it never fits very well after that. We come in and adjust and say, no, we try and adjust it. I don't even try. I say, look, you're just not going to wear the partial. And that is factored into the costings. So as soon as the costings go, they're either going to get a suspension bridge for X amount. We charge $300. The lab charges about $100 to $150 out of that. So it's not like a huge fortune money maker. Or we're going to have a direct implant, a temporary screw directly into the implant. My fee for that's $800, because there's the lab and there's 2 components you've got to buy that come about $300. So you've got about $400 profit. And so they pay for one or the other, okay? But they don't go toothless. Posteriors, they always go toothless. So there's that case again, and there's that suspension bridge. And they find, if you do it right, and you've got a technician, you've got 2 techos on site basically, and it can look pretty damn good. And people say, well, that's fine for a single, what about a partial case like that? The patient's going to get rid of this partial, it's got a huge flange, and if you have a look at this ridge, which I'll show you in a minute, it's quite thin. So she's going to need a graft. Because she's going to need a graft, it's going to be like in 2 or 3 stages, and again, this decision by the surgeon, and so, but she's not going to wear that over a graft, I promise you, or it'll fail. And so there's some of the surgery. You can see this is now wider. She's got a couple of temporaries back here. She's another implant there that we're doing. And so in that case, she's worn a suspension bridge. Okay? And that works. Even though it's, about, what is it, half a dozen teeth supported on about 3 or 4 posterior teeth. It's what I tell them, it's called a looker, not a chewer. So you only wear that when you're going out. You don't wear it sleeping. As soon as you get home, you take it out. You wear it when you're in public. And it does the job perfectly okay. It's when they get into trouble is they try and go out and then try and eat with it. And really, if you're going to eat with it, it's not going to last very long. The average life of one of those is maybe 3 months. And then some people call them an SX retainer. I don't like the SX, it's a brand. and it's stronger. It's not very clear. It doesn't look very nice. This looks quite reasonable with the lip down. And so that's it there. She's still got sutures in, so it's like immediately after surgery. She just wasn't going to go without any teeth, and she certainly wasn't going to wear that. And that's just her finished up. There you go. And that's all ceramic now. There's all zirconia. So that's for a single or a partial. With a full arch, if you go like that, then what we tell them is you're not wearing anything for 2 weeks. Okay. And then 2 weeks later, you then reline the denture, the full denture, full lower, full upper. What I do is I gut the denture so it's quite thin, and that allows more of the reline material. I personally use stuff called viscogel because it's very soft. It acts like a cushion, like silicone. And if you have a look, that's one I did not long ago, and that's a full denture where we couldn't load, and so I relined it, gives me a nice impression, allows you to practice your full denture material. So they've got two options. They can leave keeping a glass of beer by the bedside, or they can have that, and that seems to work pretty well. But you only do that 2 weeks after, so there's still 2 weeks of no teeth. Now I know you can do all sorts of ways of doing this stuff, but we get pretty good results. I just realised I'm moving around a lot. Are you trying to follow me?
So good.
That's good. My mother said I got the perfect face for radio, so I don't know what. So on the other hand, if you can load, okay, you've got 2 ways of doing it. You can make something chair side as a temporary, and that applies to a single tooth or a full arch or anything in between, or you can get the lab to do it. So if you're going to load, you can do something chair side, or you can do it by the lab technician. Simple as that. Okay, so if you look at doing it chair side, you can do it by the surgeon who does it, or the dentist an hour later. So if you're doing your own, if you're placing implants and you're restoring them at the same time, doing the provisional straight after you finish the surgery, so put down your scalpel, pick up a couple of other things and make a provisional chair side, that has a lot of advantage. The patient's numb, they walk out with a temporary tooth. I'm not a fan of that system because we've got a lab on site. It often gives you a better result, but you do get quite better at it. If you're not doing your own surgery, then the patient can have their surgery and then go straight from surgery to the dentist, or the next day it comes down to logistics. But either way, you do this chair side. The most common way of doing it, you can buy this component, which is an immediate temporary button, which is that thing. And you screw it into the implant, and you've got to tighten it 35 centimetres, and then you have a thing that fits over it, and then you get some sort of, you can either get like an alginate impression like you make temporaries for a normal crown, or a key, or you can get one of those director type crowns, and you reline it based on that, and you cement it into place. You can get better at it. I've got a couple of those components that I've done a couple of as like an emergency, but basically that's not what we do. But if you're doing your own surgery, or if you want to see the patient the next day, it's certainly, compared to the sort of money we're charging, it probably costs a third, but I don't like the result compared to what the lab makes. It's not me, it's not what I do. The other way you can do it is you can make a whole provisional, and you convert a full denture by hollowing it out and adding some cylinders and cold cure those in, and you cut away the flanges. We'll show you when we get the full arches, and make a chair side doing it that way. That's something called the Hong Kong bridge, which means it started. So we'll show that in a minute, okay? That's if you're doing it chair side. If you're doing it in the lab, basically you need an impression of that implant or implants, or you need what's called a registration, okay? This is where people, I know when we do this on the courses, people find it hard to follow. Because I'm going to go through it really fast, it's going to be even harder to follow. But basically, you'll sort of get the overall principle. So you need a model, and that model, like I said, is by an impression or an implant registration. Here we've got an impression, normal, everyday impression. It happens to be an open tray impression coping or a custom tray. You can use closed tray, you can use metal trays. And here we've got this registration. Now, does anyone know what I'm talking about there? Anyone? I don't. So, they're not laughing at jokes, I'm going home. So, this is what we mean by an implant level registration. Just kind of follow as best you can. the implant's about to go in. There's the surgical template. We've got a line to guide the surgeon about the long axis. There's some lines at the back you can't see. So the implant's about to go in, and there's the implant diagrammatically, and the implant's put into that location. Then what you do is you get an impression coping and you screw it into the implant. It's inside this, it should be inside, not outside. And so you screw the impression coping onto the implant, into the implant. Once you've screwed the impression coping, you see it here, you then get, now you can use, we use Duralake, I'm used to it, you can use LifeCare Concert, LifeCare CIC, anything that will relate this template, which is, you can see the edge of the template there, the stem, to this impression coping which is sticking out. So now, the impression coping and the template are together, and you can't take the template out because Duralake's locked it into the impression coping, which is screwed into the implant. So when you unscrew that, the two should come out together. And that is your impression, or equivalent of your impression. If you don't follow it, that's fine. If you want to come and there are thousands of them at work, and give us a ring and I'll come and demonstrate. So that's it there. Then what happens is you go to the lab. So that thing there is there to have unscrewed it out of the mouth. Then screw an implant analogue or replica into the base of that, and you're going to put that on a model. And because that's so long, you gut the model like that to make room, and you pour new stone or plaster into that. So now you've got a model with that in it, and that's still attached. So you unscrew that and leave that behind. So pour new stone, happens to be die stone. There's an implant replica. You unscrew that, and you've got that. And that's the same as your impression. So a registration. In order to do that, you need a tooth either side to locate your template. Okay. So that's what's called a reconstituted model, and the technician makes the template on that. So there it is there, there's the first step, that's what comes out of the mouth. We then cut the model away to make that, put a replica in, you take that away, you're left with that, and we go that way, and you're left with that. And so then what the technician does is get a denture tooth, sticky wax at either side, hollows it out from behind, keeps it short, and then marries that with some cold cure at the back with this temporary abutment. And there's two types, there's plastic and titanium. We never use the plastic, it doesn't last very long. We always use titanium, if anyone's going to do this. So here's a case in point. This tooth's coming out for obvious reasons. It's lateral, again, great dentition, had an endo. Often you have at a young age looking at the side of the pulp, and that's fractured, and so that's coming out. Now here we've got the implant registration. We take that out and make a model like I just showed you. Then that's the denture tooth. And the thing is, that goes in usually the next day. That's 2 weeks out. The sutures have just come out. Okay? And the idea is that it guides the tissue. This is now 4 weeks. There's 2, there's 4. There's 6. And there's completed. Okay? So the whole idea is you're trying to guide the tissues. And here's another case which shows a bit more of what I'm talking about. This tooth's coming out. What happens is two things. You can see here very clearly we keep this out of occlusion. Okay, no one disputes that. And also we under contour this slightly, only slightly, because you don't allow the papillae to grow in. If you got these too thin or too fat, too wide, the papillae can't grow in there. That's already occupying the space. So we under contour then. People say, well, how much? Well, by that much. I can't put a figure on it. It's just how it is. It's about that much. So the interesting thing is that's the temporary, that's a year later, whenever, and you see the contours are achieved. A bit of redness there still, but that's gone from that to that. So I'll just show you the patient start to finish. I'm not sure how we're going for time. Oh no, we're doing pretty good. I'll be done in an hour from now. So here's a patient, congenitally missing laterals again, perfectly nice, good man, young guy, early to mid-20s. And one of the things I'd emphasise for everyone doing any of this, and I say this in all the lectures and all the courses, but you know, guys ring up all the time, you want to take, if you're doing photographs and if you're doing study model like a workup, pre-operative workup, you always want to take photographs and study models with and without the partial. Okay? See, we've got photographs with the partial in. That gives you a huge amount of information. Patients sometimes say, oh, you know, why taking a mould of what I've got? That's not what I want to end up with. So yeah, that's the baseline. It gives you what you start with. It's a record both clinically and legally. So we always take photos and study models with or without partial or full denture or partial denture. So there he is at the back, from the side. And again, we got, with and without the partial, because that, he's got a higher or lower lip line, as you showed the papillae or not, etc. And there it is, nice young guy, and very good, well-designed partial. Not mine, but it's very well designed. It's a great rest and keeps away from the tissues. But you want something fixed, simple as that. So here we are doing surgery, and there's a surgical template with some guides along it. So what the surgeon's done is now put the 2 implants in. They're the 2 implants, and he's got a sort of mini flap, if you like, virtually just a crestal incision with a retraction. You can tell what size they are from that if you know what to look for. They're narrow because it's a lateral. So he's put the implants in, and there's a protocol about where this trilobe goes, and we'll talk about that. So what he's done is these are the impression copings. So we've screwed the impression copings into the implant. Okay? We then put the template or stent back, and then, so they're the impression copings, there's the end of it, and what happens is he's going to durulate the stent to that. And that's what, some of that's blood, some of that's durulate. Now, like I said, you can use composite, LifeCare, GIC. If you use something red, you can't tell where the blood is, so that's a bonus. And so he sutures up, and the patient goes home like that. Then I come tomorrow, and based on that, where you sewed the model and reconstituted and the temporary and the sticky wax, the surgeon makes a provisional. Now, on the courses, I've done it many a time. A lot of my courses are on a Friday, and what we've done, like a single tooth course I'll talk about, we'll get a patient in and we line it up for surgery, and they'll have surgery around lunchtime because I've asked him to do it then. And then he does all this stuff, around 1, 2 o'clock. The patient comes to me about 4 o'clock while we're having lectures and stuff in my room, which is not far from his rooms. And we insert 2 temporaries, and the technician's taking about 2 hours to do it. And people come up and then say, look, I spoke to my lab and they say it takes 2 weeks. Well, it's not rocket science. You can do that in an hour. And I won't go into how, but you do it. It's not hard. So there's the same patient. They go home like that. There's the registration. There's the 2 provisionals. Again, they're hollowed out. And again, look at where the surgery's gone. It's what I call bullseyes. They've gone right in the middle of the palatal surface. Because this guy, the surgeon makes you look good or bad. This guy makes you look good. The other thing is that there's different, we always use titanium, not plastic, provisional cylinders or abutments, because the plastic ones are just no good for this. And always make sure they're what's called engaging, so they stop, they're an anti-rotation element. And this case happens to be like what we call a conical connection, because we do a lot of that, which I won't go into. So this is the one, next day the guy comes in like that. There's the 2 provisionals. We numb him up again, that's the only difference. So if you do a chair side, you still numb, which is quite good. So put in the provisional, screw them in. And so this is like 1 day post-op. This is now 12 days. You see, he's just had the sutures out probably. There's a PA. You can tell they're temporary because they're hollowed out cylinders. You can tell it's got platform shifting like that is. We can see that there. And this is sort of a modern version, if you like. That's a week later. That's 2 months later. The problem with these provisional is, and I'm only half being funny, is they're too good. Patients will come back, say, what's wrong with it? Just keep this one. So it's plastic, it's going to break. And I've got one guy walking around for about 2 years like that, saying, it's going to break, I want to get the final one. Because the way my fee structure is, they pay very little at this stage, most of it's at the other end. Sweet, don't just be honest about it. It's going to break, I'll take the chances, I just want to get it next year. So I've got a couple like that. So there's your 1 week, 2 months. Let's do the final one. This is one of the things the provisionals do. They help shape this soft tissue. And so there's your provisional and there's your final on zirconia. And again, you see the radiographs, there's provisional and there's final, you can see the difference. And that's him finished up. And he was happy, Larry. one last patient. This guy's a dentist, works not far from here. And he had the central that he finally, after a few years, the endodontist said it's playing up, it's cracked, it's coming out. You only get one chance at this. I know you know this guy, Washi. And, you know, so that's coming out. It's not a bad crown. It's had it there for 20 or 30 years, I don't know. So the surgeon took the thing out, placed an implant, no flap, placed the healing abutment, and this is 3 hours post-surgery, literally. He just went and came to our place. Not quite enough to not have to numb him, so we numbed him up. And so we made it temporary like that. Same process I mentioned earlier, and he's still bleeding, like I said, 3 hours later, and he walks out like that. You can see it's a bit shorter. I promise you it's a bit thinner, so he can't bite on that. This is 3 months later, and you still see it's shorter. There's the final crown, all zirc, and there's one of these Nobel Active. You can see this corkscrew type arrangement, and with the platform shift, and that's him finished up. So, no questions, everyone's asleep. We just talk about full arches for a little bit. There's all different scenarios about full arches, and there's whole different ways of doing it. So I just mention a little bit about them. Sorry, righto. Look, there's about 50 different ways you can do of options. You can do 5 implants, you can do 4 implants, you can do, I'm just talking about the mandible for a minute. You can do 3 between the mandible foramina, you can do 1 at the behind if the nerve allows. You can do all on 4, all on 6. And you can do over dentures and minis. I don't do many of those. You have all different types of frameworks, hybrids, monolithic, ceramic. We're not going to talk about that. That's totally different. What we're going to talk about is once you've decided what you're going to do, how do you load this thing? Big difference. And the same with the maxilla. You get all on 4, all on 6, zygos, quad zygos, hybrids, monolithic. That's, like I said, a whole lecture by itself, or 2. There's a whole bunch, these are all our patients. There's all different scenarios, all on 4 different angles. You can see the angle of that versus the angle of that. It's all to do with the angle of the anterior wall of the sinus, basically. And so, if you have a look carefully, that's a provisional. You can tell by the type of framework or not. That's their finals, their provisionals. And, like I said, you can do 6, all on 6, not all on 4. You can do zygomatics or quad zygomatics, there's 4 there, and these are all our patients, courtesy of Brent, or they're my patients. You get 2 anteriors as well as zygomatics, and you get a nice big framework like that and that. So that's almost, and there's just, you can do zygomatics with 4 anterior implants. There's all various combinations, and that's just a summary of some of them. So what I want to emphasise is that with the full arches, they're all, what I like to think of, has 3 parts to it. What you do before the surgery, what you do during the surgery, and what you do after the surgery in terms of lab work. Simple as that. When you go through the 3 stages, all the full arches need a full denture. If there's 2 arches, they need a full denture. So even if they've got all their teeth, even if they've got some teeth, even if they've got no teeth, they need a new full denture, full denture. Okay? Because that becomes the guide of where the implants are going to go and where the provisionals are going to go. So that's got to be, it might have to fit as well, it might need secondary impressions, but you're going to have a really good full denture in every other aspect in terms of like vertical, midline, etc., occlusion, lip support. So you've got 3 options. You've got a patient coming in with no teeth, or they've got some teeth like that, or they've got most of their teeth. And all these 3 patients are going to have a full arch or 2 full arches of implants. And they're the 3 scenarios that are going to walk into your room. So the other big thing, like I said, is always keep a set of untouched originals and get a set of photos with or without the partial. So you really, really want to keep those. So we take a lot of impressions, a lot of alginate. Now, if they come in with a denture that's satisfactory, you can just duplicate it. It's as simple as that. You duplicate the denture if that's satisfactory. And you can duplicate it in cold cure, because you're going to use this as a template, or you can duplicate it and make a total copy denture. There's advantages to that. Even though I've got a denture, that could be a fallback plan B position, a second denture you can then adjust. So you can duplicate it. If on the other hand they've got dentures that are not satisfactory, you have to make them a satisfactory denture which they're never going to wear. Okay? Now, as making a satisfactory denture which they're never going to wear, because that's going to form the template or the basis of where the implants go and where the teeth are going to go and where the temporaries are going to go. Okay? But in both those scenarios, you can try them in, and you can sort of have try just like a normal denture. If on the other hand you do an immediate, so patients like that third patient, they've got all their teeth, you still have to make a full denture, but you've got a lot less room for error because they're never going to try that in. You're going to take the teeth out and then the denture's going to come into play. It's like any other full immediate denture, you can't try it in. And that becomes, you'll be extra careful of those. So, you know, if they're dentureless, you can do all this and make them a really nice denture, and then you convert that into a surgical template by cutting out holes in windows and cutting out flanges, I'll show you in a minute. If they've got a partially dentate like that, you can still do a try-in, and you try in whatever you can. At least it helps you try in the vertical. Things you've got the occlusion right. You can check that you've got the midline. That reminds me, their midline may or may not be correct. They've got a central incisor here. I have to look for a lot of patients to get exactly showing, making the point. But their midline is here because they've still got one central. That may or may not be the midline you want, depending on the face, the lowers in between the eyes and all that. So you have to make sure that you mark the midline. It could be over here, it quite happens sometimes. It could be over here. You have to let the technician know because they're going to make an immediate denture, and they're going to make an immediate denture of the midline based on that midline, which is may or may not be what you want. So very carefully mark the midline and assess your vertical aesthetics and all of that. So you can still do that with some of these partial cases that are partially dentate. This third patient is going to have all these teeth out and get implants and get a denture, so you can't try the denture in. Okay? You still need to make a denture, but you can't do a try-in. You still need to mark the midline, still have some idea of the vertical, the occlusion, etc. Okay? You might want to open the vertical, for instance, like this sort of patient, which you probably would. So now you're flying a little bit blind, as it were, but it's like any other immediate. And that's another reason why we make provisionals first and then, final restorations later. Okay? The other thing is patients have got perio problems. What we do, well, we used to, take them out, treat the perio, not treat the perio, wait 2-3 months and then go. That's not what we do now. Certainly not what I do. And there's many ways of doing this. What we do is we treat the perio of those teeth and then take them out. The idea, usually our therapist, hygienist does it, and they have 2 sessions of root planing and oral hygiene. And so we don't send them to a periodontist, like if you've got to keep the teeth. You do it more like in-house. And the idea is you try to keep the number of bugs down. Okay? So we treat the perio, and then that also gives you an idea of assessing. We usually do it 4 weeks before and then 2 weeks before. That gives you an idea of assessing your oral hygiene, their response and everything. Okay? Then that denture we just talked about, when you get to surgery now, so now we're about to do surgery, you convert that, and what we do with the upper, you just cut out a big window like that, keep this middle bit for strength, and I want all the implants to come out in there, and and that's it. We don't have individual teeth that we line up. Okay? Lower, pretty much the same. Couple of things, when I get the full lower made, I ask them for the lingual flares to be a bit thicker, because I'm going to cut this window out, and I had one break because it's quite thin. So again, they're never going to wear it, I just want this thicker. The other thing we do is we reduce the height of these flanges in terms of, you try and get good extensions up the mucobuccal fold. Well, we then cut that back. The reason being is that when they have surgery, when the surgeon raises the flap, that gets in the way, so you can't reseat it. So we cut we do it like that first, then we cut these flanges down, we ask for thicker bits there, we make sure to try and cover rectomolar pads, and we cut the flanges in height down there. And that's another reason why we do this in this sort of like a denture, not cold cure. if you can't load this, and that's happened 1 in 30 cases, I'd fill this with acrylic, pink acrylic or white acrylic. I'd gut the back of it, reline it, and they've got some sort of thing they can get on with. That's their plan B. If this is all calcul, you couldn't do that. So then we try and get that back looking something like that. But not for 2 weeks. So then what do we do during surgery? Well, here we are about to do surgery. So this patient's having full upper denture and a mandibular hybrid. Okay? So this is down the track because she ended up having full upper a few months later because she liked the lower so much, she wanted the uppers done. So we have thickened the lingual, reduced the flange height, same thing there. Okay? So here we are at surgery. The surgeon's taken out those 4 or 5 teeth and we've got full upper immediate. Okay? Just a full upper immediate denture. Then on the mandible he's taken out these teeth. And what he's done is he's flattened these crests. They're going to resorb anyway, and he's flattened until they're flat, and that allows him to put the implants in immediately. He's gone from that to that immediately. I've got a picture. He now uses a little electric buzz saw from, I don't know about bunnies, but one of his hand saws, and you see, I should have put it in. It's only started 6 months ago, and he goes zzz and flattens it like that. Unbelievable. And really good result. That's Brent, of course. So then what we do is put in these abutments. These are final abutments called multi units. Then we take an impression all during surgery, okay? We actually put on these impression coating, then suture around it, okay? So suture it around and then take, so put those on now, not after he's sutured, because you can't get them in so easily. See, now he's sutured around. We take an impression. We use metal trays because they can be autoclaved. Everything you take to surgery, with the exception of the impression guns, which can't be autoclaved, is autoclaved and then all use disposable. And then we take an impression, and it's just how to do the impression with special bits and pieces. I'm not going to go into that at all. And then we do an occlusal registration, and there's all sorts of ways of doing it, and I'll show you that in a minute. We use these temporary cylinders. That's the only thing we use temporary cylinders for is occlusal registration, not to make it provisional. There's the little healing caps on the other one, so we're only using 2. And then from there we've got the impression, and we've got a bite, occlusal registration. That goes to the lab. And that's 7 to 10 days now. It's not 2 days. Realistically, we say 7 days. It depends on the healing. So that we've inserted that. 5 months later, this is what it looks like. In this case, we've got plenty of big spaces there. You can tell it's temporary by the type of cylinders. And there's a full upper, and we've got a shortened arch. For our temporaries, we don't have very much in the way of cantilevers, and that's another reason why if you go straight to a final, you're an idiot, because we have short cantilevers because of load. So this is 5 months later. During those 5 months, this lady decided the lives were so good, even though temporary, she wanted the uppers done. So you wait and so marry them together, restore them at the same time. So now we're doing the upper. This is 5 months later. A bit of bone there. There's going to have a bit of bone there. These are angle abutments, if you know what they look like. They look different to that. We put these impression coatings on, suture up, take an impression. Do an occlusal registration. I'll show a bit more about that in a minute. And now this is 7 days later, so this is 5 months and 7 days, if you like. There's the upper, it's healing, so you've got plenty of room for cleaning, I promise you. And I'll tell you another thing, 20 years ago, they didn't have much room for cleaning. Everyone used to go up. And what happened was, the saving grace was that we didn't do full uppers very much. For each full upper that we did, we probably did 20 full lowers. So they weren't that common. And most of those ended up going very difficult, so to clean. And these days, they can all be cleaned. Big difference, big difference. So in terms of doing occlusal registration, this happens to be one way of duplicating calcul. What you do is, so there's a copy denture in calcul, and that gives you all that stuff. So you've got abutments on, this is down the track, you can do it at any stage. What we do is place these temporary cylinders and we cut them so the opposing arch doesn't interfere. And so cut these windows out because you try those in, and where these come out, you cut out 2 windows labially. And so then you've got to insert these. This is actually in the patient's mouth. So mark where those windows are, you cut them out, put these cylinders, cut them to length, put some cotton wool in there so you can't get stuff inside. And then you can see these aren't touching, and these are screwed in. So durolay that to that, or composite that to that, so you can no longer take this out if you durolay to that and that's screwed in. You do it on the opposing areas, and so then what you end up with is that. So that is now durolayed to that, and that's what it looks like. The advantage of this is you've got that denture, which is what I said before, is you're going to make a really damn good denture. It's got the right vertical, right midline, right tooth position, right occlusion, because this is what the final, not the final, but the temp is going to be based on. Okay, so you then take that. You've got an impression, remember, or two impressions. So that's what they look like. You can see there. You then mount those on the impression that you've made on the models. You then throw these in the bin, or you take keys and all sorts of things. Then you make your provisionals on that. You don't use these for anything else other than to relate your models. Okay. And you can see here they've been cut back, like I said earlier. And that's the provisionals. If you go straight to finals, you know, the tissue contours change. Even with guided surgery, no flaps or minimal flaps, they change. You need to assess the patient's oral hygiene and see how well they can clean and how much spaces you've got to give them. They change their minds all the time. I don't want A2, I want A1, etc., etc. When you go to a final, what are you going to do? It really makes absolutely no sense. We have those cases I showed you with cantilevers. We don't have cantilevers because of loading till the final. So what are you going to do? You know, success rate's 90 to 99%. So sometimes an implant will fail. You've already finished. If an implant fails when they've got provisional on, you can put another one in somewhere else. You can change the provisional. You can keep going. If you made the final and the implants failed, you're in the poo. And so you're really compromising your lab work, because the way they do these overnight things is not the way that it's done when you do it over a week. And I won't go into that, but it's compromised. The lab work is compromised. So you can do a chair side, as I said before. So what you do is basically get a denture like that. You've got a model, or you can do it in the lab, in the patient's mouth, sorry. You cut out these holes where these cylinders go. You seek the denture over those. You cut these to length, and you calculate that to that. You cut away the flanges, and there's your provisional. You do a chair side. There it is there, they're sutured in place. These are out of a journal, by the way. And so, you know, they sutured, they put these on, and then they put those things on, cut the length, and then they calcule the bits. You cut away the flanges, throw more calcula on, and there's your temporary. Well, it's okay, but it's not what I do. Then you cut away the trim. The problem is, number one, it's really weak, because you don't chemically bond to these cylinders, and you've gutted the denture, so it's really, really weak, and you're going to be there a few months, so it can very easily break. You've got no actual model to sit it on, because you haven't taken an impression, just a study model. They're not heat cured, they're cold cured, because you've done it in the mouth and you've added a bit. You know, it's very good for a short-term solution, but it's not like good long-term, and it's fiddly and time-consuming. So I don't see why people want to do that. And if you want to do it, so be it. And this is out of the West Australian. Some guy here, I don't know who that is. It can be achieved in as little as 4 days, okay? But these days, look at today's ads, they're done overnight. You get teeth in a day, and you've all seen those ads. And it got better, because all teeth on 4 implants, dental implants, it's sort of a war on out there in advertising, because it used to be 4 days, but now it can be done in 1 to 3 days. And the immediate teeth are final and not temporary. It says it right there. You know, it just makes 0 sense. And there it is there, okay? And now we can do it in 24 hours. So, and straight out of the thing. All on 24 hours, final teeth. Think about it. I just said all that. And just show you a case, we're just about finished, you'll be pleased to know. This patient's got a bit of an extensive breach, that's had an endo, one of these teeth is fractured. Once that one's fractured, she's not going to be left with much. So she's going to have a full arch of implants. She's got lichen planus, which is being treated by Gareth, got babies, and these teeth have been compromised. They're going to have some implants at the back here. So going implants there, and a full upper arch. And there's no room there for implants. So that's what she looks like intraorally. So it looks okay, except that when you look closer, not much there. And so what we did is all those steps, which I won't go through again, and 6 months later she got a provisional and she can clean those and it followed the contours. In the meantime, because of the way we designed the treatment plan, the lower posteriors have been now finished. They're all ceramic or PFMs. They're not, I don't use acrylic for any of that situation. The only time I use acrylic is the full upper, a full lower arch, or sometimes full upper arch. So we finished those. You see these have got shortened arches. What we're doing here is, these aren't temporary, so you're not wearing these. We're in the process of making the final, it's going to be all ceramic. In order to do that, we want to know where the contours are going to be, because it's such a big, extensive, full arch ceramic job, we want to know the exact contours we're going to finish up with and then copy that. So this is not what she's wearing. We do a verification jig, verify the model, that's critical. This happens to be die stone, there's different ways of doing that. There she's finished up, she's got all on 4 up the top, again nothing at the back. She's got cantilever there and there, she's got 3 units there and there. And there she's finished up. And so you've got posteriors there, etc. I'm only going to talk about partial cases for 2 slides, because A, of time, and B, the partial cases are the same but different as a single and full arch. I've shown you 2 extremes. The difference with the partial cases is this. Excuse me. With a single tooth, you can keep it out of occlusion. With a full arch, you can have, because of the framework, the implants are splintered because it's a full arch from one side to the other. With a partial, you can't really do either of those. So, the other thing is, with a single tooth, you're really trying to preserve, or a couple of single teeth, you're really trying to preserve the soft tissues. With a partial, say something like that, or that, 4 incisors, or 6, or 7, or 8, or those, the soft tissues are mostly gone. So if you're trying to preserve those, you're kidding yourself. They're not there in the first place. So the reality of the situation is that we do a lot more, we still do some, but we do a lot more immediate loading or function with single teeth and full arch and partials for that reason. We still do it, and other than that, if you do it, the procedure and protocol is the same. So this case here with the full flange, I said, and the graft and every other thing, she's had some implants down there as well. And again, it's all zirconia, and the rest of it in between is the same. I'm just about finished. They're just a little request, I guess. What we do is, if you want to take some tips home, etc., we keep all the labels in the patient's card. Okay. So when we're using a abutment, we don't worry about little prosthetic screws. It's mostly the abutments. We keep it and put them in. A, you prove what system you used. Not sort of a cheap overseas one. If there's any recalls, you've got the batch number, and it tells you exactly there's another unit, Brandon mark, wide platform, 1mm, there's a reference number, and we always keep that. So, it's no big deal to get stuck in the patient's card. The other thing that I started doing about 3 or 4 years ago, maybe more, is go back to a few hundred patients, and there's 4 different patients here. Hopefully I know their names, I know. We cut this into 4 and laminate it, and they get a little covering letter. And we get quite a few patients from over east, over all over the place. And a lot of them, some had problems, and you sort of think, what the hell you have done? And you guys, some of you guys can relate to this. You don't know what system they had, you don't know what to talk it to, you know what to use, you're pulling your hair out saying, well, what do I do? So at least for my patients, what I've started doing, as I say, going back in time, is they get a little thing that's saying, stage 1 surgery was 2005, stage 2 2006, provisional 2006, you replace select regular platform, 30mm angulated, you tighten it to 15 Newton centimetres, etc., etc., etc. And we got 3 copies of that. We actually cut into 4, so we do 4 patients at once. We laminate it, put my little logo on the back for advertising, and then we send it to them in a covering letter. We've also got an index, like a library of all of them, and another copy goes in the patient's card. So they get one, the folder with all of them gets one alphabetically, and then an actual card, we've got cards for each one. And, you know, so at least if they go somewhere else, we had a few lately in the last year or two say, oh, so you're retiring. I said, no, I'm not bloody retiring, I'm doing you a service. So, and in actual fact, the last perio, I don't know what they call it, the Perio Academy, they had a meeting here 3 months ago. I didn't go. I didn't go. And so one of the things that came up was they're trying to get a world registry of what implants people had. I don't know if it's ever going to fly, but all I know is for my patients, they get back, and I've been going back and back and back, and you know, it's quite interesting. And anyone wants them, I've got heaps of those with, you know, no names on. You can do, there's 4 there, there's 3 there, you can do a single, etc. And it's really, really worthwhile. It's a really good service for your patient. The other thing that we do is have a checklist every time we've got surgery, and we do one of these today for tomorrow. What a button's going to take, impression copings, price screws, blah, 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 and I fill that out when the nurse takes it. Because if you go to surgery and you haven't got something, you can't just go back in the stereo and grab it. So I fill all that out, and then we pack it and the bag together. And anyone that wants one, they're welcome to it. Again, contact me. I'm quite happy to give you one. You have to make up your own, because what I take might be quite different to what you take. So in summary, basically, I'd say, for single teeth, in my situation, I'd say immediate placement, immediate function, etc. Probably 3/4 of them get it. We do that in probably 75% of cases. Premolars, about 30%. Mostly if they're single rooted. If you've got double rooted tooth, then you really can't do that because you've got to go up the septum. Molars, we do it in about 0% of cases. We just don't. They don't get temporaries, they don't get nothing. And they get teeth eventually. Again, with function, probably half of the anterior teeth get function. In other words, the other half go to plan B, they get a suspension bridge. Premolars, maybe again 20%. With premolars, we make the temporary look a bit like a canine. Not for an upper, the most palatable cusp, but certainly thinner, it's much shorter, half the occlusal height, and keep it out of occlusion. The molars, again, never. Full arches, look, you know, immediate to lowest, 98% of the time. Nearly always, one in a blue moon, not maxilla, more and more, but certainly only, and this is not set in stone, it's just what I do when I practice, okay? Partial cases, again, anteriors maybe 60%, the other anterior we don't. So I try to emphasise it's not a panacea. Posterior 0, simple as that. So the other thing I'd like to finish with, or almost is do implants work. I think I mentioned this, all this immediate stuff works. It works if you follow the protocol. And if you follow the protocol, it's only, you can only do it in a certain percentage of cases, which is what we do. So I'd like to show you one particular case. This is actually me. And so you've got to sort of, you know, you've got to believe in what you do. So I made an executive decision towards the end of last year. I've been putting off for about 5 years. And this molar's fractured there, and you know, it's got recession you can't see. This a friend of mine did a crown there not long ago. It didn't go so well, it's quite deep. And one of these, this other one, I thought, no, that's going. So I decided I'd have 3 implants. So this is done, you know, they had to work, so those 3 are coming out, okay? This is me. This is the day of surgery. I was in the guy's recovery room, got my phone out, took a selfie. So but if you have a look more carefully, the only bit of blood is a bit of blood there and a bit of blood on the pressure pack, but the rest of it looks as good as I ever got to look. And so the next morning, that was me. And this is, you know, quite true. So I've gone from that to that overnight. I feel like I could have played footy the next day, seriously. It was really good. And this is now, this is where I am now. I'll be having impressions next week. So I've got healing abutments, implants, they look pretty integrated, which is very pleased about that. And so, again, this is me. There's some wide platforms there and there. There's some amalgam there that are probably 40 or 50 years old. I'd actually like someone to show me a composite that's 40 or 50 years old that's still there. I mean, if I ever replaced them, they'll be white, the crowns, but at the moment, they're there. So you've got those 2 there, gold there. And I had those golds from dental school. So one day I'll change them. But no, I've still got my ads up there, nothing down there. So yeah, implants is better work. This is my other passion. This is my car, and I do a lot of four-wheel driving about every week, not every weekend, one weekend a month. And without fail, I can promise you, I go in the club, there's usually half a dozen or 10 cars. I'd say 9 times out of 10 I get sent in first because it's a capable car. I won't say it's a capable driver, but this is getting quite. This is down south. It's looking quite amazing. And this goes up to the bonnet, and that's me going through there. And we got through okay. This one didn't quite make it. This is one of the trips, and this guy was supposed to straddle that ravine, not go into it. And so he got stuck. He couldn't open the door. We asked him, do you want anything off the roof? Because it's quite easy to get to. So he didn't quite make it. This is another trip. He didn't quite make it either. And again, that's not me. The other one was. This is me at Lancelin, and there were about 10 cars tried to get up this hill. And these tracks, because they're coming down, these guys got up to about there, going up, going about there, and literally. So if you know what to do and you've got the right car, you can sort of get up there, burn a bit of smoke. I reckon I got a bit of smoke blowing out of my backside, so I guess they're right. And this is another trip at Lancelin, and this was even more heroic. This is again about 6 guys tried. I said, Lazar, off you go. So okay. I had 2 kids in the car, my friends' 2 kids are this big, so I chucked everybody out because this looked quite tricky. And 8 cars didn't make it, and I'm going, oh, I can do this. Oh, hang on, go back one. So let me just show you, it's only a very quick video. Here we go. Oh, it's not yeah. Wait a minute, I was trying to show you. Oh, here we go. No, it's not. It's all these voiceovers with the kids going, you're never going to make it, you're never going to make it. what you do is you prepare the thing, so you flatten the take-off area, so flatten there, you can go up and down 2 or 3 times. The best part of this is the voice, which I can't get on for some reason, it worked earlier. So then you go back about 10 miles towards Perth and take you this giant. And there's the kids trying to video. That's the nurse's husband and the kids. My kids don't want to go anymore, so I borrow them. It's true. And then you have this, he's never going to make it, he's never going to make it. And you go, oh crap! And he goes up. And that's quite, the video doesn't do it justice, so,
All right.
So that's about it.